Hey there everyone, this is Rich Slama, and in today's 5-minute lecture series we're going to be going over abdominal aortic aneurysms. So what is an abdominal aortic aneurysm? It is a true aneurysm, meaning that it involves all three layers of the artery, including the intima, the media, and the adventitia, and it occurs anywhere in the abdominal aortic area, so usually anywhere below the level of the diaphragm. So most of these, 85% of them, are going to occur below the renal arteries, and they can extend into the iliac arteries. And these are defined by an aortic diameter greater than 3 centimeters or an iliac aneurysm greater than 1.5 centimeters. And if you understand the anatomy, then you understand some of the complications that can occur from these. So if these occur below the level of the kidneys, you can have bowel ischemia. It can press on one of the ureters, particularly on the left, and cause hydronephrosis. It can rupture, and it can fistulize with numerous different viscera in the abdomen. It can fistulize with the aorta, and so with the IVC rather. So you can see where this can be a pretty big problem for emergency medicine physicians. So in terms of the risk factors for this disease, these are going to be your vasculopath patients that you typically think about. So hypertension, diabetes, history of smoking, age over 55. The pathophysiology behind this is that you actually get a deposition of lipids in the tunica media of the artery, which leads to weakening of the artery, and it gets broken down by numerous enzymes within the body. And so there's a lot of different things that can lead to this. It's usually a conglomeration of multiple different risk factors. Smoking is probably one of the most important ones. And then, how do they present? So these patients can typically present with very nonspecific symptoms. They can have abdominal pain. They can have just this nonspecific flank pain. The pulsatile abdominal mass that can be present, and that is certainly helpful if you feel a pulsatile abdominal mass. But I can tell you that I've examined thousands of abdomens ever since I left med school, and I don't think I've ever truly felt a pulsatile abdominal mass. So it's very subjective. That being said, these are not always 100%. There's nothing that is 100% diagnostic in terms of your physical exam for this. Syncope can happen in these, particularly when they rupture, but again, that's more of a secondary sign. And so how do we diagnose these? In the emergency department, one of the very cool things that we have is ultrasound, and ultrasound has become one of the main modalities that we can use to at least screen patients for these in the emergency department. And so let's go over some of the anatomy here very quickly. If you'll look here, we've got the vertebral body, which is posteriorly. So this would be a curvilinear probe on the abdomen. So vertebral body here. The hypoechoic area here in the middle is the lumen of the aorta. And if you look just outside of this, you'll see an area that's a little bit more hyperechoic, and then a ring surrounding all this. So what you have here is you have a thrombus inside of the aorta where the media used to be, and then on the outside of that you have the old wall of the aorta, which is the adventitia here. And so the way that we diagnose this, at least in the emergency department, is any patient who has an aortic diameter greater than 3 centimeters. And certainly anything greater than 5.5 centimeters needs surgical intervention on a more urgent basis. Now, that's if you have a stable patient. If your patient is unstable or you're suspecting rupture, obviously you want to get your vascular surgeon involved, but if you're suspecting rupture of the aortic aneurysm or an active leak of the aneurysm, then what you want to do is get a CT angiogram of the abdominal aortic aneurysm. So anatomy here, we're going to look at the right kidney over here, left kidney here, vertebral body once again. This is a lobe of the liver, some small bowel over here on the right-hand side of the screen. You've got your IVC here, and this is your aorta, and extending from the aorta is this very large aneurysmal sac. So if you're suspecting that somebody is ruptured, then your diagnostic study of choice, if the patient is stable enough to go to get a study, is a CT angiogram. And this is a little bit more sensitive than ultrasound. This is actually close to 100%, whereas ultrasound is 95% sensitive for diagnosing this. The better thing about a CT angiogram compared to an ultrasound is that this can detect if there is active extravasation of blood, whereas an ultrasound will not usually show you that. So that's just one of the main benefits to getting this over an ultrasound study. So I included this because this is just an overview for those of you who are not so much visual learners, just a quick summary. So if you want to go ahead and read over this, you can go ahead and pause. So there are a couple of pitfalls here that can happen if you're not taking care of these patients. So hematuria is a particular concern, not so much in your young patients, but anybody over the age of 50 who's having new onset hematuria, you really have to question yourself as to what's causing that. It's not always kidney stones. In patients who have a ruptured aortic aneurysm, what can happen is one of two things. They can compress one of the ureters, which can lead to hematuria, or they can actually have an aortocaval fistula, which in turn causes increased central venous pressure. And what has been written in the literature is that this increased central venous pressure causes backup in the kidneys, which leads secondarily to hematuria. So just be aware that anybody in the emergency department over the age of 50 to 55 with new onset hematuria who's never been screened before, you should probably screen them with at least an ultrasound for an aortic aneurysm. So that being said, I hope this lecture was useful, and I hope you can translate it to your clinical practice. And until next time, thank you for watching.